Oh, hi, Stephen. Hi, everyone. How are you doing?
I'd like to say a little bit about our doctor with us today. Many of you probably already know him, but if you don't, he is the director of the Global Biorisk Advisory Council. He's had over 25 years of technical experience in dealing and responding with infectious disease outbreaks, as well as emergency management. He's worked with the U.S. and international governments, United Nations agencies, and even private sectors. He's worked all over the world as well, in Asia, the Middle East, Africa. I might note that he's also an assistant professor in the Department of Public Health Sciences at Penn State College. He's appeared on numerous other entities such as CNN, Fox News, BBC, Canada. I could go on for many minutes, but we are very lucky today to have him here with us. Thank you for joining us.
No, you're very welcome.
So I called you a couple months ago and I asked you about possibly doing this. And the reason, of course, is the current outbreak that we're seeing hopefully coming to a close in Uganda. How are we doing in Uganda right now, and how does that kind of compare to previous outbreaks?
This is a really good discussion to start with, Stephen, because the outbreak that started, September this year, again, full transparency, the Ugandan government is very well prepared to handle an Ebola outbreak, or not just an Ebola virus outbreak, but also a high consequence disease outbreak. You know, there's other viruses out there that we're concerned about. So it was reported back in September, and it's a little bit different than the outbreak we had in 2014 that, again, has still the most significant, the largest Ebola outbreak that we've ever recorded. This outbreak right now, I think we've got about 140. There are 2 confirmed cases. We're looking at about 55 deaths, about a 40% case fatality rate that we know of. But about 87 people have recovered. But the concern we have right now is the fact that this outbreak in Uganda has spread to, I know we should call them in Ugandan districts, 9 Ugandan districts, but think of these are like states, and they've spread to a very large geographic region. And because our diagnostic capability in the US, in many other countries, including Uganda, is limited when it comes to a disease like Ebola, our resources within our public health, our hospital healthcare system is limited. Our laboratory diagnosis is limited. So when we map these cases out, we're seeing a large geographical spread. But the other concern that we have is that with Ebola, we have to follow up with the contacts, these key contacts, people that have had close physical contact, usually with a known case. And those numbers are now up to about 5,000 people. And why we have, this is what's really interesting. We've got confirmed disease in 9 Ugandan districts, but we have contacts being monitored in 15 districts. So I think the key point here is that when it comes to a high consequence disease or a serious disease like the Ebola virus disease, it doesn't just stay in one. And so it's very interesting that we've now got 9 districts confirmed. We've got 15 districts involved in contact tracing. Now, the other very sad thing here, Stephen, is that we do know, going back to the 2014 outbreak, I had 3 trips to West Africa to manage Ebola hospitals. But for this Ugandan hospital, just like that outbreak, we had a lot of our hospital staff get infected. We have 19 healthcare workers right now that we know have been infected and laboratory diagnosed. 7 have died. There's another 22 probable cases that have died, but they died before samples were obtained for confirmation. Really, really concerning that even with a small number of 142 confirmed cases, we've had a significant number of healthcare workers infected.
Well, it's concerning to us as a state because we have been monitoring individuals that have been to these regions, not necessarily contacts, but even in our own county here, we've been monitoring several people over the last few months. So this is something that feels like we say to ourselves, it doesn't hit close to home, but it could very well hit close to home.
Yeah, it's a good point. There's only one international airport in Uganda, Entebbe, where they are doing some screening before passengers leave. And then each passenger in Uganda is required to complete a health declaration form. Now, this is, if you want to get out of the country, you want to go on a visit, you want to come to an event, or you want to visit family, this is the weakness we have in the system, and we've had it for years in our serious diseases, high consequence pathogen system, is that we require self-reporting. We don't have the ability to screen in real time at these airports. And again, our biggest risk right now is someone in Uganda or a family in Uganda saying, hey, I want to come to the US to visit family for the holidays, or there's this really important conference or meeting that I've been locked up with COVID for a couple of years. I want to get out of the country and jump on a plane. It's going to come in through an airport. And so we do know that all travelers leaving Uganda are being screened, but it's really, again, very similar to what I experienced coming back from, I was in Paris, France last week for meetings. I came back on what did I get back in on Sunday, and I had to self-report. It's like they had signs up at the Washington, D.C. airport here going, have you traveled to African countries? Do you have the following symptoms? And I said, no. Well, everyone can say no. So there's some challenges there of how do we triage, how do we respectively treat or talk to someone who's traveled from Uganda in a way that we're being respectful, but we're trying to protect the larger, do the greater good, to protect that large public health system that we work in, ensuring that what we're doing is because we're kind, we're compassionate, but we just want to make sure that we don't start our own outbreak, say in the state of Tennessee.
Is it possible that some individuals could even be possibly symptomatic and then come back to the States knowing that they would be able to get care here that they possibly would not be able to get in other countries?
This was something that I really wasn't well educated, or I understood the system of within our healthcare system. The fact that back in 2014, we had this discussion of the number of people in many countries that fly to the US for specific procedures. They come here for different laboratory diagnostic tests. They come because they can afford, they have the money to come and be part of our healthcare system. And I really hadn't, as an epidemiologist back in 2014, looked at the numbers of people that travel to the US for routine healthcare or special healthcare for particular disorders they might have. And it's big business for many of our hospitals. I now understand that. And I understand that when we've had other high consequence disease outbreaks like Ebola, Marburg, Lassa fever, other people have traveled here because the healthcare system is very, very good. And it's better than where they are located overseas. And that's a concern that I think I've been on lots of meetings at both the federal government and at state government level where we've been talking about what is if someone has come for a particular procedure here in the US, they self-report that they haven't been to one of those 9 districts where there are known Ebola patients in Uganda, and they get through the system. It's possible. And I think that's something we've got to be very cognizant about. It could happen. And I think being prepared for that outbreak, that eventuality, is not that difficult. It's just something that we've been so busy in public health and hospitals recently that it's another thing to put on our list, but it's something we should be well prepared for, not just Ebola, but for many other, I would say, high consequence pathogens.
We've actually had healthcare workers in this country become infected that did not travel abroad, correct? And taking care of a patient with Ebola.
Yes, we did. And that happened back with the 2014 outbreak. And again, this is all public knowledge. Stephen, we know that a gentleman traveled from West Africa. His name was Eric Thomas Duncan. He left. We're not sure whether he had a headache or body aches or a fever before he left. We know of another story where a patient left Liberia and brought Ebola into Nigeria And we pretty much believe that he was aware that he was sick at the time when he jumped on a plane. He must have taken some Tylenol or something else to lower the temperature to get on the plane and sit there and not be but and then he subsequently died in Nigeria, and then led to the cases that we had in Nigeria that myself and a team responded, went to Nigeria back in 2014 to help the Nigerian government. So we know that Eric Thomas Duncan, who we again, case studies have been, we teach this at universities, we teach it in hospitals. This gentleman did come back to visit family, visit some loved ones. He traveled down to Dallas, Texas. I think it was a Thursday, he went to Texas Health Presbyterian Hospital with a travel history. He had come from overseas. He had the typical "I'm not well" symptoms, which again are not specific for Ebola. They're very flu-like, they're COVID-like, many other diseases of those early symptoms. And he was sent home. He was sent back to his apartment. And then a couple of days later, it got worse, and he was subsequently admitted to Texas Health Presbyterian Hospital with Ebola. And it was a situation there. It's a very good hospital, but again, the time he was admitted, the staff that were on shift at that stage just didn't have a lot of experience with high consequence pathogens or serious diseases. So we know Nina Pham was one of the nurses that was infected. That's public knowledge. We know Amber Vinson was the other nurse, and I was a professional witness in the cases that discussed about both Nina Pham and Amber, and what could have been done better. And it was really just down to slow things down. When you have an Ebola patient or any high consequence pathogen patient, the fact is you've got to get them into isolation, and then you've just got to stop, take a big deep breath, and go, okay, what do I need to do to protect the room, the hospital, my workers, my staff, my space, my equipment? How am I going to manage the waste? And go through those checklists. We're pretty well prepared now with checklists. We can familiarize ourselves with that, understand what needs to be done. And I think going back to those experiences that I had in 2014 here in the US, but also on my second visit to West Africa, I arrived and I was sent to a hospital where 26 doctors and nurses had just died from Ebola. So when you walk into a hospital and you're told to help them, and they've just lost 26 of their colleagues, their friends, and they're dead, morale is really low. And it was a hard hospital to work in. And we just had to say, time out, stop. And we actually had about 210 patients in that hospital at that time, Stephen. And we stopped work for a day and a half just to get everyone practicing, rehearsing. We brought in the buddy system. You work in pairs. I watch you, you watch me. We slow things down, helping people put on and take off the personal protective equipment, giving them, redoing the schedules, giving them enough breaks. That I can say that once we set that up, and this was an Ebola treatment unit that was in a school with 210 patients. We lost a few. Unfortunately, it's very sad that people did die in that day and a half where we just couldn't go in there. But I think once we went in there, we didn't lose any more healthcare staff, and that was critical. They had lost 26. And I think the lesson learned here now is that we can practice, we can rehearse, we can do small base discussions, we can do small drills. The drills, the discussions that I practice in, that I help facilitate in many hospitals, they're no more than 20, 30 minutes. That's it. You do that a couple of times a month, and it keeps everyone prepared, ready. It gives them the confidence. Because I can tell you now, I've seen a couple of thousand Ebola patients in my trips to West Africa. I'm scared. I'm nervous. I take a deep breath. Oh my gosh, I'm going back into the Ebola hospital. It's hard work. But again, we can do better in our preparedness just through practice.
With COVID, the way it's taken our healthcare system, we've lost so many providers and workers. There's been a general weariness. And I think that's led a lot to, with this current outbreak, it's been difficult to get healthcare systems on board with being prepared for a possible Ebola patient. I feel like a lot of healthcare workers feel like that they would be comfortable with an Ebola patient because they've taken care of COVID patients, and perhaps some of that, that PPE handling would transfer well over to an Ebola patient. But as you said, high risk pathogen, how would that be different as far as a COVID patient transferring over to an Ebola patient?
Yeah, it's a really good question, because you have to think along the lines of systems, and then you have to think along the lines of the community, the people that work in those systems. So the challenge we had, in my first trip to West Africa in Nigeria, we had a part of the hospital that we were helping set up. I had a team that I took over there, setting up an Ebola treatment unit that had 10 beds. And the discussion we kept having from day one was, what happens if we have 11 patients and we've only got 10 beds? What happens if we go to 12? Now, with those 10 beds, we were given one ambulance. And we went, oh, we've got one ambulance. Well, what happens if we have a family of 5? Which was the case in 2014. We had lots of family cases, so outbreaks, confirmed cases, and we had to move the family. But we've only got one ambulance, because with the way that we were working with the health system, we couldn't take another ambulance out of the system and make it an Ebola. And the fact that was, again, with an Ebola situation or a high consequence pathogen, engaging with the community is really, really important. Now, the big mistake we made in 2014 in Nigeria, we didn't talk to the community. And I think it was a Wednesday, we got our first Ebola patient. Our one ambulance went out. They did a fantastic job. The EMS guys, the ambulance guys did a great job. They picked up the patient from the community, the house where this person was sick, brought them in. The nurses, the doctors, the staff that we'd trained did a fantastic job of getting on the patient handoff, getting the patient out of the ambulance into the Ebola treatment room we had, and then got them comfortable. Everyone was really confident. And Dr. Parker was the state minister, or the state director of health. And I walked out and he said, "Gavin, who's cleaning the ambulance?" And I went, "Oh, geez, we haven't trained anyone, Dr. Parker." He said, "Well, the ambulance has got to be cleaned before it goes out again." And so suddenly we had a real problem on our hand, because it wasn't on our checklist. We now had an ambulance. And again, this patient came in, had some vomiting and diarrhea. So we had some, we definitely had virus in there, and we had to clean the ambulance. And we did it ourselves with the local staff, trying to teach them. Now, what I liked, the next day we got our second patient, and we had used a sheet of plastic to develop like a swimming pool, and taped it up in the back of the ambulance. So when we put the patient in, yes, that patient had vomiting and diarrhea, but then we could just Velcro, we could just remove the plastic and bring it out. And it actually protected all the other equipment and parts of that ambulance from the vomit and the diarrhea. And again, everyone on this call, if you haven't seen an Ebola patient has more diarrhea than you could ever imagine. It is it's gray, it smells, it's awful, it stinks, and then they have a lot of vomiting. So it was a Wednesday night. We got our first patient into the Ebola hospital. We got attacked by the community that night. We think there was about 3,000 people came and attacked the hospital. We were scared. They didn't destroy anything. They spray painted messages throughout the hospital. They had guns, they had weapons. The safest place to go and hide is to put your personal protective equipment on and get in with the Ebola patient. And that's what we did, all of us. So we now had an Ebola patient with nearly 6 of us in PPE, standing there scared, going, what if these people come in? And they never came in. They came past the door, but they never came in. The next day, some lawyers turned up and said, you owe us, the government's got to pay $1 million because you brought an Ebola patient into the hospital. And the government said, no, we're not going to pay $1 million. And we actually sat down with the community saying what were their concerns, and they just hadn't been included.
That's interesting, because that could very well happen here. I mean, we could draw a lot of knowledge and information from that we didn't have to let the public know.
Exactly. So we hadn't communicated effectively in any way of what was happening in their hospital, their local hospital, which was their hospital. They owned that hospital. And they felt, that hospital was it is. It's a part of their critical infrastructure. And so the solution there was that 2 of the community were put onto the hospital board, the executive board, and they attended all the board meetings. And the community accepted that. And we didn't get attacked again. We brought in more Ebola patients over the next couple of days, the next week or so. And the community, again, we were very transparent. So that communication is different. You had to engage the community. But then with an Ebola patient, you've got, cleaning. There's lots and lots of cleaning. The vomit and diarrhea continuously. I think if I go back to 2014, we had lots of how to clean up spills. And I just want to emphasize, Stephen, I think the studies are a little bit behind what we actually saw in the Ebola hospitals that I worked into as well. Anything that's wet that comes out of an Ebola patient has virus in it. Anything that's wet. So you make a full list of all the things that come out of a person's body that are wet. And it's not just the blood, it was everything. The tears, the urine, the semen, the milk from a mother who was breastfeeding, saliva, the vomiting, the diarrhea, anything, the sweat, everything that was wet, we could find virus in. So you've got to protect yourself from anything that's wet. And then you've got just management issues. What do you do with your staff? We had a lot of staff, both in West Africa as well as here in the US, that were treating Ebola patients. It was known they were treating Ebola patients, and their communities, even in the US here, didn't want them to come back home. So where do you put those critical staff, the nurses, the doctors, the laboratorians, the EMS, the ambulance drivers? Where can they stay and stay safely so they can come back to hospital for the next shift?
It does pose questions, because once you've committed to taking care of that patient, you basically have committed that you're going to be sequestered away from your family, other coworkers, and everyone, I would imagine. It's very isolating.
And I think the personal connection as a professional that I made, and I know many others of my friends and colleagues made with Ebola patients, we really felt part of them. It's really something. It's Ebola when you've got your personal protective equipment on, Ebola patients like to touch you. They're scared. They're worried about what comes next. And I wasn't ready for that in 2014. I'd been to an outbreak in 2009, but it was a much smaller outbreak. This was a much larger outbreak where we had 210 patients in that hospital on my second visit, and they all wanted to touch me. And especially, I wasn't prepared for the number of children that came into the hospital, and the kids wanted to touch me. And they didn't just touch me, they grabbed my Tyvek suit and they never wanted to let go. And I would then, I've got my 2 pairs of gloves on, my extended cuffs up here to my middle of my arm, and I'm trying to be compassionate. I'm trying to be a professional and show I understand. I didn't wear an N95 in 2014. I wore a powered air purifying respirator, a PAPA. I haven't worn an N95 in a hospital for a very, very long time. Even for COVID, I wore PAPAs all the time. And many of the people that I work with on my team wear PAPAs. So we were wearing PAPAs while other people in the same hospital with the same patients were wearing N95s. So with the PAPA, they could see my facial expressions very clearly. But I can tell you, when the little kids start putting their hands on the outside of your PAPA, that's scary. And you come out and you've got fingerprints all over the face of it, and you're like, wow, that was close. That was really something else.
I worry that an Ebola patient, or a patient that would come in saying that they've been to another country, that they're having the symptoms, that they're having maybe some myalgia, fever, and then they say, I've been to another country. There's so many other viruses and diseases they could carry, but I worry that for my own hospitals, that we're not prepared for this. Just like we weren't prepared for COVID. I worry because I know for a fact that even our own travel clinic, we've had people, missionaries, we've had healthcare workers that have gone over to Uganda during this time of need. And I don't think people understand how world traveled we really are. We think that we don't go to these far reaches of the world. But we do every day, and we have so many people that go out there, and then they come back. What happens when they come back to the States, as far as someone that's even if they've just been a tourist on the edge, maybe they were in the Congo or somewhere like that. What usually generally happens when they come back to the U.S. to give us assurance that they did not possibly bring this back with them?
People are wonderful. It's absolutely amazing what they will volunteer to do, what they'll give up their time to do. And I've always been surprised when I've traveled, sort of internationally or even here in the States, the number of people that have just turned up because they're compassionate, they care, they're kind, and they want to help. They need to be trained. What we have found sort of more informally is trying to develop a community. It's really important that people that have volunteered overseas in a disaster, an emergency, a high consequence pathogen like Ebola, for example, that they have someone they can talk to. And that's where the community comes in with the buddy system. There are a number of us that are out there in social media, on the website, where people know, oh gosh, you worked with an Ebola patient back in 2014. Yes, I did. Can I ask you a few questions? And I've never said no, but you do get that, where people want to just reach out and say, should I invite everyone over for Christmas for dinner, or should I do this? And I know for the fact that I come back, I isolating yourself for 21 days is really hard, but that's the requirement for Ebola. And I know that when we went through we're still dealing with COVID, trying to get people to isolate is really difficult to do. And with the 3 trips that I had to West Africa, the whole team, when we came back, we isolated ourselves for 21 days. I had, and the people I work with are friends. Friends came back and said, I can't go to this state because the governor has said that if I land, I'm going to go to this. Gavin, can I stay in your basement for 21 days? I said, yeah, of course you can. So I had people staying in my house, trying to go just to reinsure each other. So it's really important. There's a community out there. I'd like to formalize it a little bit better. I'd like to sort of connect the dots. I know from working with Nebraska, Emory University, I know working with Texas health staff down there, that everyone who had dealt or had been in the vicinity of an Ebola patient wanted to be part of something. And so it's really important when we look at our plans, we look at our exercises, we have our discussions about what to do with an Ebola patient. We think about the fact that we have to develop a community. We have to have ways to talk to each other. In 2014, it was text message. We text message each other all the time, like in the days on the hospital, in the wards. Outside now we use WhatsApp and other communications. But it's really important you develop that community where people can actually ask questions and just vent, just talk about their experiences.
Going forward, I guess, what would you like to see in a perfect world as far as preparedness goes, from a hospital standpoint, from a community standpoint? What do you see? What would you like to see? Because this is just this year. We've had several outbreaks. This was, I guess, comparatively a lighter outbreak than the one in 2014, but who's to say the next one won't be worse or appear in a different area and catch them off guard? What would you like to see as far as perhaps the hospitals and healthcare entities in the United States do to look towards this? Because we're not going to start traveling. Traveling has increased back up again, and we're going to be exposed to this.
The fact that we can do this, the fact that, and again, I'm very much an advocate for who are the essential employees, and it's who are the essential employees when it comes to a systems-based approach for an Ebola virus disease patient, and it's a lot. And it's like my story in Nigeria, where we hadn't thought about cleaning and disinfecting the ambulance. I see it here in the US on exercises that I facilitate all the time. They're going to bring in the ambulance. Everyone then rehearses and practices the patient handoff, which goes really well. And then I'm standing there going, I've got a really contaminated ambulance now. I've got an ambulance full of Ebola. What's happening next? Oh, it's going to park over there in the car park. And no. It's got to be better than that. You've got to actually get the checklist out and formalize and run through the steps to make sure it's safe. The ability of equipment. We bring, we saw this in 2014. We brought hospital equipment into those rooms, and then suddenly people within the hospital, our colleagues, our professionals, said, that ventilator is not coming back into this other ward. That other piece of equipment is not coming out of the Ebola hospital into but it's been cleaned and disinfected, and we've swabbed it. It's safe. No, and I saw lots of equipment, especially here in the US, that were put aside in a room for 6 or 7 months, and then quietly, silently put back into the hospital system without anyone knowing that that was the piece of equipment that was used to care for and treat the Ebola patient. So we've got to get over that. We've got to go over that and actually define what our skills and abilities are. We can do it. Define how do we work safely with equipment, with, again, staff, space, and stuff. And that shows that what we do is, again, it's evidence-based, it's scientific, it's the best we can do, and not get caught up in a lot of the discussion we had, even with COVID, Stephen, was like, is it airborne? Is it contact? Is it droplet? No, guys, I'm trying to tell you, anything that's wet that comes out of the body, we found high viral load in anything that's wet. And if you understand how you spread infection, cross-contamination, how you spread viruses around the hospital, how do you get infected? Protect your eyes, your nose, your mouth. We were saying, telling people, just protect your holes. And they got it. Protect your holes.
It's interesting because it will say, when you read the literature, it will go on how this is not respiratory. It'll say that 15 ways, but it really doesn't just simply say manage the secretions and the fluids. It just, for some reason, you're absolutely right. It doesn't put the emphasis on the right side of the management.
It doesn't. And again, we were putting, again, we had just copious amounts of gray, awful smelling diarrhea to clean up. And everyone was going, it was on the Ebola team was going, well, whose responsibility is it to clean up? Who, at that time, anyone who's in the personal protective equipment, in the room, in the facility, has to learn how to manage a spill. That was a different way of thinking in the hospitals that I worked in than what they prepped, because they would say, no, I'm a specialist in this. I don't do spill cleanups. You do now. And then going back to training, this is how you cordon off that area. This is how you clean up the spill. We can put things down the toilet. Hang on, wait a minute. The toilet doesn't have a lid. Why not? Because when we flush the toilet without the lid, we know that, we call it the toilet sneeze. We know it aerosolizes back in the air. We've got wonderful photos, video that people have taken through. We can show stuff. Why don't we have lids on toilets? Because you've got to. So suddenly you've got virus everywhere. The fact that the diarrhea, the vomiting, just the procedures we were doing with the Ebola patients was actually just splashing a lot of these wet body fluids around the space, around the room.
Okay, that's why saw lidded toilets are necessary. I understand that now. So.
Yeah. So again, going from the commode at the bedside to the toilet to flush down the waste, which again is safe, and we can put it in the sewage system. We do that all the time, and then treating, and then going and treating the toilet with the disinfectant. But the point is that we didn't think like that, and we didn't think about the possibility of reservoirs of virus within the room, and we knew that there are places where this virus just survived. And if it stayed in the corner and we didn't touch the corner, then it's not a risk. But if we went over and we picked something off the floor, or we touched a wall, or we touched a table, or we had, a hard non-porous surface like a table, but we also had soft porous surfaces. What do we do with those soft porous? Again, no one had answers for these. What do we do with? Yes, a mattress did get infected in the apartment in Texas. How do you dispose of a mattress now that has Ebola virus all through it, which it did, and it's massive, and it took, was it 4 people to carry the mattress out of the apartment, down the stairs, and put it in a truck to go for incineration? It was a big job.
Very good. Well, I tell you what, I feel that we've kept you on for a while. Is there anything else that you would like to say in closing, as far as other things that you've noticed as far as what it does to a community, or the sequela, or the lingering effects after a patient's recovered from Ebola, things that you've noticed of interest in association with Ebola?
Yeah, I think the contact tracing, the triage is challenging. We're going to have to rely on people telling the truth. But when we do have people, patients under investigation, whatever we call them, contact tracing is challenging. What we did in Nigeria, Liberia, and Sierra Leone, we used university students for the contact tracing. So with the public health departments who didn't have the person power or the person resources to do all we were following up with these people, twice a day. As I said, again, the latest report that came out from Uganda, there's 5,000 people right now in 15 different districts that are being contacted twice a day for 21 days. Go back to public health, our public health department, go, you ready for this? Because you're not. And they're using university students to do that. And I think it's really important. There are people that we can get within our community, volunteers, as well as university students that can actually then strengthen our system. I know that for COVID-19, in some jurisdictions, at the county level and the state level, I saw the use of volunteers that worked really well when it came to contact tracing for, say, COVID-19. And those things need to be better put into place, whether it's a community emergency response team, or the CERTs, which we have with FEMA, or some other volunteer organization that, hey guys, if we get someone in and we know they've gone to a hotel, a restaurant, a shopping mall, they came in through the airport, we might have a few contacts on our list and we're going to be overwhelmed. It'd be great to have that ready to go. And then the other point is that the fact that we're going to have our messaging. Our messaging has to be better. It's not the fact that we're going to put up a poster on the wall that reminds people to wash their hands for 20 seconds, because that doesn't work. It's the fact that we're going to have to identify what are the key messages we need to get out to the community, to the healthcare staff, on how to manage the situation, not just the patient, the situation, and how do we practice? If you go back to the bombing of the Boston Marathon and the hospitals, there's three level 1 trauma centers in Boston, and you talk, how do they do so well? And then they go, we exercise, we practice all the time. I think even the smallest hospital, not just the large, but even the smallest hospital where they may get a traveler from Uganda come in, are the ones that we can still help them. We can still help them through, let's do a 15-minute what if exercise this week, just to keep everyone thinking that this might happen. It's not cost prohibitive, it's doable. We just haven't been able to get ourselves, to my opinion, organized in a way that we create a culture of continuous improvement.
And that mentality, sure. All right, well, once again, I thank you so much for taking the time, taking your lunch to spend with us.